Good afternoon. We're live. It's Thursday, June 18th, 2020, and this is the weekly healthcare provider webinar presented by the New York State Department of Health here in Albany. I'm Dr. Elizabeth Dufour, Medical Director in the Division of Epidemiology at the State Department of Health. Joining us this week to update healthcare workers with our latest guidance on COVID-19 is Dr. Marcus Friedrich. Due to the large amount of interest in our weekly COVID-19 guidance updates, we are offering a few different ways to listen to this webinar live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our healthcare provider's webpage. It's mobile friendly, so you can watch right on your smartphone or tablet. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov, click on the providers link at the top of the page, then click on Weekly Healthcare Provider Update, and it's available immediately after the live webinar concludes. The weekly healthcare provider webinar is also available as a podcast. Search your favorite podcast store for NYSDOH or Healthcare Provider COVID. The podcast feed is updated by Friday morning, and the show notes will contain reference links and other important information discussed during the webinar. On the agenda for today, we have the usual global, national, and New York State updates. Updates in the testing realm and community mitigation and reopening. Treatment updates, and updates on the multi-system inflammatory syndrome in children associated with COVID. Dr. Friedrich will give us updates on elective surgeries, hospital visitation, and encouraging access to health care. And Dr. Louis Nitkoff will give us updates and quick tips on healthcare provider wellness. We'll then review resources briefly and a pre-planned question and answer session, as the chat box is not feasible with the level of attendance. However, we have pulled questions from those that have been sent to our email inbox from you all. Again, here's the link for the recordings that will be available immediately after and during this webinar session. And the information today is presented based on the best knowledge as of today. So looking at the global picture, we see now over 8 million confirmed cases globally with over 440,000 deaths. Notable here, as you look at the different regions globally, is that the Americas accounts for almost 4 million confirmed cases and over 200,000 deaths. Here we see the global map with the two areas, again, as in the past, highlighted as having more than 100,000 cases in the last 7 days, being the U.S. and Brazil. Here we see the WHO global epidemic curve, and we note here that the area in yellow is the area of the Americas that has a significant portion, again, of the global burden. We see that the area in the red color is Europe, and that has decreased in the proportion over time. And we see an increase here in the purple coloration, where we see an increase, and as well in the green color, indicating Southeast Asia. So we are seeing some increases in the Eastern Mediterranean and Southeast Asia as well. Here we see continued presence of a CDC travel advisory and alert and recommendation that U.S. citizens avoid all non-essential travel throughout the globe, given global levels of ongoing community-wide transmission of COVID-19. And now looking at the CDC situation summary of the national picture. As mentioned, we're now over 2 million cases nationally, with over 116,000 deaths in the U.S. And here's the national epidemic curve. We do see a plateauing of this daily number of cases in the U.S. over time. However, as is noted in the lay press, we do know that New York and other states have had a decrease in our number of cases, as we will discuss in the next slides. And there are several states, over 20 states, who have had increasing numbers of late. And now to look at the New York State picture. So we have here, this is information that was available this morning as of June 17th, posting from June 16th data presented here in the slide. However, verbally, I will give you an update of the June 17th data that will be posted shortly. We've now had over 3 million persons tested with molecular testing in New York State since the pandemic began. And as of the 17th, 68,541 tests were performed on the 17th alone, 618 of which were positive. And the importance of this is to indicate that it's a 0.9% positivity rate, the lowest percent positive since the pandemic began in New York State. And here we see a graphic representation of the number of tests being done in New York State, which has continued to increase, as you are aware, and then the number of positive tests in the yellow color, which has continued to decrease to that most recent 0.9%. Sadly, we've now reached 24,629 fatalities statewide. And as far as the healthcare utilization picture, as many are aware, we continue to see decreases in hospitalizations due to COVID, ICU admissions, and intubation numbers, with some of the lowest hospitalization numbers since we started looking at these numbers early in the outbreak. Currently hospitalized is 1,358, decreased by 121 from the day prior, and newly hospitalized is 76. Currently in the ICU is 388, decreased by 43, and current intubations 278, decreased by 26. Fatalities for yesterday were at 29, which is slightly up from 17 the day prior, but still the picture is overall much lower numbers in fatalities, thankfully. And cumulative discharges at 69,243. Now for some updates on SARS-CoV testing for COVID. So this is a familiar slide of the New York State criteria for COVID-19 testing, and I'm not going to repeat all of these categories of individuals eligible for testing. However, I will mention the addition of one element at the very bottom there is anyone who attended a recent protest is eligible for a test. So that is a new addition since the last webinar 2 weeks ago, and the rest of the criteria for eligibility for testing are here for your reference. Again, for reference, here are the acceptable specimens, so the nasopharyngeal swab, or the anterior nares, and oropharyngeal swab, or the anterior nares. Saliva is an option depending on the lab, and the available medium that can be used is here for reference. So one important aspect of moving forward at this point is the identification of specific areas highly impacted by COVID-19, where we continue to see ongoing transmission, also known as sort of hotspots. And so to address this moving forward, as we reopen, there have been 14 new testing sites at churches located in communities particularly impacted by COVID-19 being set up in partnership with Northwell Health and Somos Community Care, as well as 11 new testing sites. This has been announced since our last webinar in communities particularly impacted by COVID-19 in partnership with CORE, a community-based organization about community organized relief effort. And again, in relation to the protests and the concerns of possible transmission in this setting, 15 testing sites are being prioritized across the city for individuals who have participated in recent protests. And again, all of those locations, their availability, how to sign up, the location, the hours are all available on this website, and the link is on this slide for you here, as well as the COVID hotline can be used, or the New York State DOH COVID website, where individuals can be screened for eligibility. Since our last webinar, there have been additional sero surveys completed in New York State, looking at 12,000 individuals across the state who received antibody testing and looking for antibody reactivity, indicating recent or prior COVID-19 infection. And the results revealed a 13.4% overall positivity with a reactive COVID-19 antibody testing, compared to the prior 12.3% positivity from the testing performed in mid-April that was previously presented on these webinars. So an increase of about 1.1%. So a much slower increase than previously, but that is consistent with the numbers that we have seen decreasing after social distancing measures were in place, a decreased number of positive tests with molecular testing. And newly available and published here on this slide is an Annals of Epidemiology paper with my Department of Health colleagues, along with colleagues at the SUNY School of Public Health at University of Albany, where the information from the sero survey in mid-April was analyzed to provide a fuller picture of the population and number infected. So the New York State statewide seroprevalence study was using that previously shared information of 15,101 patrons that were tested in a convenience approach at 99 grocery stores in 26 counties in mid-April. Based on 1,887 positives out of those 15,000 individuals at a rate of 12.5%, an estimated cumulative incidence through March 29th was estimated at 14%. Again, this is the mid-April testing, but looking back, recognizing the delay from infection to serologic testing reactivity. So the estimated cumulative incidence through March 29th was 14% statewide, corresponding with 2,139,300 infection-experienced adults estimated. The cumulative incidence was highest in New York City at 22.7% and higher among Hispanic, Latino, non-Hispanic Black, African American at 29.2% and 20.2% respectively, among non-Hispanic Asian at 12%, compared to non-Hispanic white adults at 8.1%, and that was statistically significant difference. As mentioned previously, all of these serosurveys are performed in those 18 years of age and older. An estimated 8.9% of infections in New York State were diagnosed. Diagnosis highest among adults greater than or equal to 55 years. And in conclusion, from this largest U.S. serosurvey to date, an estimated more than 2 million adult New York residents were infected through late March. And of course, the substantial health disparities were identified. Hopefully, moving forward, we'll have further analyses coming out of the new serosurvey as well. Now, a couple brief updates on testing resources and hand hygiene resources. This slide has been shared previously and is an example of a flyer that can be shared with patients when they are undergoing COVID-19 molecular testing, advising them of what next steps they should take. Again, just sharing this again, it can be obtained in English or in Spanish, either by clicking on this link to get this printable form, or on the next slide, you'll see inbox that can be emailed in order to order materials from the State Health Department. And likewise for this contact tracing tool that can be utilized when testing an individual and can get a jump start on the important contact tracing that needs to be done if the individual is positive. And this is a flyer for those contacts of the individual who is positive. Again, likewise can be ordered. And some FAQs on testing that can be used for patients. But notably, I did want to share a new resource available today. These are mirror clings, and individuals can order these for public use. So either in public settings, so you can share this with your community members, that they can use these mirror clings in public settings, such as stores or restaurants where there are bathrooms, or in your healthcare settings, these can be utilized. And again, here is the email, bmcc@health.ny.gov, where these can be ordered from the State Health Department. You'll see on the left is the English version, and in the middle there, you'll see the bilingual version, English and Spanish. And here's a picture of what that would look like on a mirror, just so you can see that in use. Now to review some community mitigation and reopening strategy updates. So as many are aware, but again, we like to provide these updates to providers as they often tell us that they're quite busy and cannot keep up with all of the facets of COVID-19. And as a resource for your patients and communities, it's helpful to receive these updates. All regions in the state are now open. And on the right, you'll see a map of the statewide regions color-coded by phase 1, 2, 3, or 4. There are no regions in phase 4 as of yet. Phase 1 reopening, as many are aware, occurred on Monday, June 8th in New York City. And New York City is on track to enter phase 2 on Monday, the 22nd. Again, phase 1 means low-risk outdoor recreational activities are allowed, construction, manufacturing, agriculture, curbside, and in-store pickup. Phase 2, currently, the Mid-Hudson Valley and Long Island are in phase 2 and on track to enter phase 3 on July 23rd and 24th, respectively. In phase 2, outdoor dining is permitted with social distancing and masks, and also allowed is office-based workers returning, again with all of the appropriate precautions, in-store retail shopping, and some barbershop and hair salon services. Reopening of places of worship with 25% occupancy was a new element added over the last 2 weeks to that phase 2 reopening structure. Phase 3, currently these regions in the bright blue on the map on the right, the Capital Region, Central New York, the Finger Lakes, the Mohawk Valley, the North Country, the Southern Tier, and Western New York have all entered phase 3 over the last with the most recent being yesterday in the capital region. This allows for indoor restaurant and food services and personal care services, such as nail salons, to resume. Gatherings of 25 people will be allowed, up from the limit of 10, and low-risk youth sports can resume on July 6th. Those include things like baseball and softball, gymnastics, field hockey, cross-country, and crew. Further information on the reopening categories that you may be asked about by your patients and community members. As many are aware, summer day camps statewide can open on June 29th. However, sleepaway camps will not be permitted this summer. Localities have been allowed to decide whether to open public pools and playgrounds based on the metrics and the locality's degree of transmission of COVID, as well as the ability to implement appropriate safety and hygiene measures. Outdoor socially distanced graduation ceremonies have been allowed with up to 150 people beginning June 26th. Again, presuming that in that locality there are no outbreaks or significant changes in metrics. And of note, so we can all have some entertainment, the U.S. Open will be held in Queens from August 31st to September without fans. We've had a lot of questions about hospital visitation. Understandably, this is incredibly challenging for families. And the hospital visitation pilot program that was launched in May has been completed in association with the hospital associations and several hospitals, and revealed that there could be successful and safe visitation for patients and families with the current rates of infection. So hospitals and group homes will now be allowed visitors. That includes group homes certified by the New York State Office for People with Developmental Disabilities. This is per the facility discretion, and of course with all of the appropriate safety measures such as visitors using PPE and having symptom and temperature checks. At this time, however, nursing homes are still prohibited from having visitors, as ongoing evaluation of the challenges of protecting the vulnerable nursing home populations have been continued to be analyzed. And on this slide, I just wanted to share with you all as healthcare providers some legislative and policy updates. While this is not normally in our realm as healthcare providers, some of these are particularly important for us as leaders in our community and during this COVID pandemic to be aware of and to counsel patients and our communities as these relate to important issues. The first is that legislation was signed banning price gouging of personal protective equipment through the remainder of the pandemic. That includes masks and hand sanitizer. Obviously, this is to help ensure access to these critical supplies for healthcare workers and the general public. And this is something that certainly I have had, and I'm sure many of you have had, individuals in your healthcare settings asking about how we can make sure that we have enough PPE going into any future waves of infections with COVID-19. And this is one of many efforts here. An executive order was signed allowing commercial buildings to conduct temperature checks for people entering office buildings as employees begin to return to offices. And legislation was signed prohibiting healthcare employees from penalizing employees for making complaints of employer violations. This allows and provides for greater healthcare worker protections to address working condition concerns and patient safety in the workplace. And we have had concerns raised to us from healthcare providers aiming to advocate for their patient populations who may be vulnerable individuals working in healthcare settings. The New York State Department of Health will also allow midwife-led birthing centers in New York State for the first time. This allows for diversity of birthing site options for moms and supports patient choice, and was one of the 6 key recommendations from the Maternity Task Force for COVID that was convened previously in the outbreak. Again, here are some resources for you over time, as well as for your communities, to look up businesses and how or when they should be reopened, reopening guidance when a question is raised, and the monitoring dashboards. Here we see the daily hospitalization summary that's available as an interactive tool by region, also available by county. And we see here, again, similar to the numbers that have been presented verbally, the number in blue of daily hospitalizations and the number in yellow of ICU admissions. And this is to allow individuals and healthcare providers to follow this over time very closely in your locality. The early warning monitoring dashboard is available here, and again, looks at several metrics, including the number of tests available in the population, the number of contact tracers, and then you can see in the upper right map here in the yellow to orange color, this is a number of cases per population. So it gives you a rate so that you can see the number of cases cases per population. And the example here is in the capital region, and you see that decreasing over time. Finally, the percent positivity is available in a user-friendly format for your communities, and you can point them to this to follow this over time as we reopen and watch these numbers closely. We've had many healthcare providers ask us about the summer day camp guidance. Of course, many family practice providers, pediatric providers are heavily engaged with their communities on this topic. So just to briefly review what that looks like, the link is available on this slide for you for the full guidance. So regarding masks, as with other mask guidance, face coverings should not be used by children under the age of 2 or for anyone who's unable to medically tolerate such covering, including campers or children for whom such covering would impact their health or mental health. And young children or campers, for instance, under the age of kindergarten entry, do not need to wear face coverings while they're in child care or day camp programs over the summer. However, older children and campers are encouraged but not required to wear face coverings as much as feasible. Employees, however, must wear face coverings at all time when interacting with children or campers, regardless of the distance between the employee and the children or campers. Some further issues in that guidance: group size of the campers must be limited to no more than 10 children or campers, and ensuring stable groups, so not having staff or counselors float between groups. So ensuring stable groups, and that these different stable groups of up to 10 children or campers have no or minimal contact with other groups and don't use common spaces at the same time to the greatest extent possible. And occupancy of the settings must never exceed 50% of the maximum capacity of the space or vehicle. Further guidance, of course, is available in detail on cleaning and disinfection, social distancing, hand hygiene stations, both for washing as well as alcohol hand sanitizer, implementing mandatory daily health screening practices of employees, any visitors or contractors that come in, and children or campers, either directly to the children or camper by the health staff with appropriate approaches, or through the parent screening, and reporting any positive cases, of course, immediately to public health authorities. Now I'd like to present some updates on therapy since our last convening 2 weeks ago. So as many may have heard, in the past we did present here in this webinar series on a Lancet article on hydroxychloroquine, which showed similar findings to what our colleagues at New York Presbyterian published in the New England Journal of Medicine, and what we had published here at the State Health Department in JAMA of a lack of benefit of hydroxychloroquine. However, please note that that study, the Lancet, and 3 of those 4 co-authors retracted that study of over 96,000 individuals from 671 hospitals was reported after there were questions raised about the validity of the data reported in the study. So that was retracted, along with a similar study in the New England Journal by the same group with a company called Surgisphere looking at ACE inhibitor use and risk with COVID. That was also retracted again due to the inability to validate this data set. Initially, the WHO suspended their clinical trials in reaction to this, as well as to pause and evaluate available data. And then they soon after resumed their clinical studies, recognizing that after the retraction of this article, that there still was room for a randomized study versus the previously published observational studies on this topic. More recently, the UK terminated their arm of the hydroxychloroquine arm of its randomized evaluation of COVID-19 therapy or recovery trial, a large national clinical trial to test the efficacy of multiple potential treatments, with hydroxychloroquine being one arm. And they terminated the enrollment in that arm after finding no evidence of treatment benefit. They produced a statement about this, of these preliminary findings on 1,542 patients. The hydroxychloroquine arm showed no significant improvements in mortality or hospital length of stay compared to the standard of care. However, the full results are yet available, so to be published in the very near future. Notably, on June 15th, just a few days ago, the FDA revoked the emergency use authorization that permitted the use of chloroquine and hydroxychloroquine donated through the Strategic National Stockpile to treat certain hospitalized patients with COVID-19. So that EUA has been revoked in response to all of the literature on the topic to date, revealing a lack of benefit and potential harm. For updates on remdesivir, again, there are no FDA-approved drugs for the treatment of COVID at this time, although remdesivir is currently available available through the FDA emergency use authorization process. Remdesivir has been distributed from the company through DHHS and New York State DOH to hospitals across the state, only to hospitals, as this is an intravenous therapy only recommended for those who are hospitalized with severe disease. There is a limited supply, but the company is working with the federal government to increase production and distribute further supply over the coming months. Notably, over the last couple days, there has been quite a bit of press about an announcement, again by the Recovery UK clinical trial on dexamethasone therapy. Again, not yet published, nor has it undergone peer review, and so this should be taken with some caution. However, they did note preliminary results were announced that among 2,104 hospitalized patients, there was a 34% decrease in mortality for patients on mechanical ventilation and a 20% decrease in mortality for those receiving supplemental oxygen therapy when compared to a non-placebo control group who received standard of care. And finally, a resource on therapeutic updates. NIH COVID-19 treatment guidelines is a very nice resource on this topic. The link is available on this slide. And these were updated a couple days ago on June 16th. A couple of the new updates, just to highlight some of these updates. They recommend remdesivir for treatment of COVID-19 in hospitalized patients with a pulse ox of less than or equal to 94% on room air, or those who require supplemental oxygen, mechanical ventilation, or ECMO. For those not intubated, they recommend 5 days for the length of therapy. For those intubated or requiring ECMO, if there's no improvement after 5 days, some experts extend the therapy for up to 10 days. Again, a new update is they recommend against the use, so a more strong against the use of chloroquine or hydroxychloroquine for the treatment of COVID-19, except in a clinical trial. And they've added a new section on the multisystem inflammatory syndrome in children associated with COVID, which I will review in a moment. A couple slides on the MIS-C in children associated with COVID. Here is a slide with the link that presents the 3 webinars that the New York State Department of Health has presented, along with clinical experts throughout the state who have experience treating MIS-C and our Pediatric Sepsis Advisory Work Group. These were available from May 14th, May 21st, and June 11th. May 14th and 21st focused on more severely ill children, and June 11th on the more mild to moderate children not requiring ICU admission. These were very helpful, and I highly recommend these if you're looking for more information in this realm. Additionally, the Greater New York Hospital Association, along with the New York State Department of Health and the New York City Department of Health and Mental Hygiene, presented an excellent webinar on that same topic of MIS-C in those who have more mild to moderate disease. Also a very useful webinar that delves in a little further into the clinical details of this topic. And finally, the NIH COVID treatment guidelines to present you what is added most recently on MIS-C treatment. Of course, they note limited information is available on the treatment of MIS-C, and supportive care remains the mainstay of therapy. And currently, there's insufficient data to recommend either for or against any specific therapeutic strategy for the management of MIS-C. However, they do note that although there is no definitive data available, many centers consider the use of IVIG, steroids, and other immunomodulators, including IL-1 and IL-6 inhibitors for therapy, antiplatelet and anticoagulant therapy. The role of antiviral medications is not clear, and they recommend MIS-C management decisions should involve a multidisciplinary team of pediatric specialists, including intensive care, infectious disease, cardiology, hematology, and rheumatology specialists. Now we'll move on to Dr. Marcus Friedrich, Chief Medical Officer, Office of Quality and Patient Safety here at the State Health Department.
Thank you, Liz, and good afternoon, everybody. Thanks for joining and taking the time again to listen to this. First, I want to mention something that the governor actually signed yesterday into law to include audio-only services into the definition of telehealth under Medicaid. This is like a really, really important piece and a strong signal to providers that this is the telehealth is here to stay, and it may have an impact also on the current temporary nature of some other payers here in the state on telehealth. So again, the Medicaid program, and I talked to them this morning, they're still evaluating the impact that this will have, but this is like a good news on the telehealth side that I wanted to share with you. Secondary, I also want to share, as you might have heard, there is an update guidance to the April 29th directive on elective surgeries. In all, elective surgeries are now approved in all counties, and all counties are open. We increased the testing requirements from 3 to 5 days prior for elective surgery. And again, there's a difference between elective surgery and urgent surgeries. If there is an urgent surgery that needs to be done in the office, and no testing can be done before that, the testing should be then done as soon as possible after that. But there's a very strong distinction between, the elective and planned surgery versus the urgent surgery that really should not wait for testing before the procedure need to be performed. And then the aerosolized procedures and high-risk procedures that practitioners should pay special attention, and wearing the right PPE, and that includes an N95 and face masks or face shields on top of the normal PPE that they will be providing. Again, we have it all very nicely summarized in our provider compilation that can be downloaded on the department's website, and also can be requested if you send a quick email to covidproviderinfo@health.ny.gov. We are more than happy to send out these recent updates on the guidance. And then Liz already mentioned the hospital visitation policy that was expanded. She mentioned the pilot that was finished. The pilot was announced on May 26, and it showed that visitation can be done safely. The hospitals are now allowed, all hospitals are allowed to accept visitors, and all group homes as well. The hospitals need to notify the Department of Health for that, and of course they have to adhere to the guidance. And there are a couple points I just want to point out. One person at a time, that also the person who is visiting needs to wear PPE and face masks and so forth. But I think, again, this is a good step going forward, and it will start actually tomorrow, this new policy, that we are going back to normal. And it was probably very hard for people to not visit their loved ones in the hospital during these challenging times. The last but not least that I again want to emphasize on this encouraging access to healthcare. We are very closely following the discussion and issues around the vaccines, and that patients are getting the right vaccines. The CDC announced a new guidance on vaccination and no longer recommended delaying adult vaccination, which is like a different from the recommendation that was previously issued from the CDC. And also they recommended catching up of the resumption of normal routine vaccination, and also recommended the guidance also started to recommend wearing a face mask during vaccination while administering it, and other things in that guidance. We and the Department of Health is currently working on also similar updating our guidance, but I just want to make you aware of that the CDC changed some of their recommendations around this, and we want, as the Department of Health, continue to encourage providers using all resources to bring the children in. And again, there is certainly in the NICES, in the state immunization information system, there are like reminder and recall functions to make you and the patients aware that they are overdue for vaccination. So please make use of that. And also the summer is coming, and there will probably be a huge backlog of vaccination. Make sure you have enough vaccinations on hand to vaccinate not only your adult but also mostly the pediatric population, who hopefully can go back to school after the summer. So with that, I'm giving it back to Liz for our next topic. Liz?
So now we'll hear further quick tips for clinician well-being in the era of COVID-19 by Dr. Louis Nitkoff.
Thank you, Liz, and good afternoon, everybody. Happy to be back with you talking about clinician well-being. Today we're going to focus on some strategies for healthcare leaders. First of all, we need to remember that as clinicians, we are all leaders in our own organizations, our practices, and our institutions. We're all looked up to, and along with that comes responsibility to act in a leadership capacity, which of course varies according to our roles within the organizations, but it is significant nonetheless. The resources that I'm using for today's session include a recent article called Supporting Clinicians During the COVID-19 Pandemic by Charlene Dewey and Associates in the Annals of Internal Medicine, and also resources from the National Academies of Medicine, and I have the link on the bottom of this slide. By way of just sort of review, the pandemic that we're in the midst of is unique because it poses long-term threats to our well-being as clinicians. And that includes our physical, mental, spiritual, and emotional well-being. Regardless of our practice location or the size of our practice, everyone in our practices must commit to supporting the well-being of those involved in patient care. One thing that can be done in institutions or larger practices is establishing a well-being committee, or in a smaller solo practice, appointing a champion who takes on this responsibility and helps implement efforts to support clinicians. And it's important that we are all attentive at this time and make efforts to support our colleagues and also support ourselves. The long-term nature of the pandemic really is a contrast with short-term emergencies. An example of that would be what New Orleans and other areas in the South experienced during Katrina, which was much more of a self-limiting event, albeit with some longer-term consequences, but different in nature from what we're experiencing now. So under these circumstances, the culture of caring really must extend to caring for the workforce. At these times, and others, really, it's important that organizations value clinicians. This needs to be articulated clearly and often by organizational leaders or by the leaders in smaller practice settings. We need to be sure that clinicians know they are valued during these stressful times and that everyone shares the goal of caring for patients and managing the pandemic together. We need to adopt and communicate best practices. And the thing about best practices is that what works best in one situation or one environment may not work in another. When asked for the definition of best practices, the best definition really is it depends. And the other thing that's important to remember about best practices is that they often evolve, and they need to evolve. So what is best today may be best today because of something we learned yesterday, and what's best tomorrow may be best because of something we learned tomorrow. Regardless of all that, it's important to be clear and transparent in our communications within our organizations and our practices, to manage expectations and provide a realistic assessment of conditions on the ground. It's important to create work schedules that enable clinicians to exercise self-care and have some resilience, and also provide sufficient resources for us as clinicians to do our jobs. We need to continually monitor and promote clinician well-being. This needs to be an activity that's proactive and compassionate and purposeful. If we don't apply ourselves to doing this, it won't get done. We need to identify opportunities and options for counseling and mental health care. Many clinicians by nature are reluctant to admit we need help, and this is especially true with our own health, and even more so with our mental health. Organizations and practices need to prioritize clinicians' personal and family safety, along with patient safety, and provide basic provisions for health and comfort. It's important to provide a supportive and blame-free work culture. We need to have safe environments that enable open discussions of our vulnerabilities, our sources of stress, our feelings of burnout, and what we perceive to be barriers to well-being. A culture of safety depends upon encouraging reporting of incidents, disruptive behavior, violence, harassment, and medical errors, and a culture of safety that enables these dialogues to occur. Also fosters patient safety. And we need to provide mechanisms for immediate follow-up and protection of victims. And remember that in the event of medical errors or unexpected adverse outcomes of our care, there are often two victims, the patient and the caregiver. We need to enable an environment of cooperation. The work of healthcare today demands teamwork. No one individual can do it all. And the most needed assistance that we receive often comes from non-clinical services, so it's important to include management, clinical and non-clinical teams in discussions about cooperation and collaboration. Finally, we need to have accessible and updated information. It's important that there be a central point of contact for updates and guidelines, and that there be a unified message within the organization, institution, or practice. It's good to use multiple channels for communication because different individuals rely upon different channels of communication. And finally, it's extremely important to include positive messaging and to reinforce the great work that clinicians are doing in the midst of very difficult circumstances, and to acknowledge how difficult it is and how much it's valued. So that concludes my comments for today. We intend to continue to provide well-being content in future sessions, so please let us know if there are topics you'd like us to cover. Thank you, and back to you, Liz.
Thank you, Dr. Snitkoff. Now we'll just review briefly some of the resources at the end here. These have been consistent, just available here for your reference: the CDC website, the New York City Department of Health and Mental Hygiene, the Office of Mental Health, some of the Medicaid telehealth updates, and some other telehealth guidance that may be of value to you. Our healthcare provider compilation of guidance, this is updated for June 17th, and here is the link for where you can find this guidance, and also the email inbox, covidproviderinfo@health.ny.gov, to send in questions for us to address on these webinars. Texting number for healthcare provider and physician and clinician wellness. Text NY Frontline to 741-741 for emotional support services. Some links for valuable healthcare provider well-being resources, and the New York State Mental Health Helpline for healthcare providers or for your communities and patients at 1-844-863-9314. And then here's the link for our New York State Department of Health website with some of the signage that we have available on how to wear face masks and coverings for the public. As you're reopening more and having more visits in the healthcare setting, some useful signage alerting patients to stop at entry and assess if they have any of these symptoms and put on a mask, and even a symptom check for entry for those who are hearing impaired. As we heard, this was a concern, particularly for elderly populations. And again, to note that since the last webinar, the New York State of Health open enrollment has been extended to July 15th. So just to be aware for your patient populations, that is extended and open until July 15th. Some resources here for phone numbers of where to call with questions. And now we'll go into the question and answer session. Before we delve into that, I will briefly say that we plan from this point forward on doing these healthcare provider updates every other week. So our next one will be July 2nd, Thursday, July 2nd from 1 to 2 p.m. And we will assess over the next several weeks whether more frequent or less frequent are appropriate based on the situational assessment. So now moving on to some questions.
So we're getting a lot of questions about the multi-inflammatory syndrome in children, and I know that you are actively involved in that here at the department. One question is, are there protocols in place in hospitals to manage children with MIS-C, including ready access to providers in New York City or New York State who already have experience managing these cases?
First, just to note those webinar links that were already shared for webinars, and you can really get a great understanding of the approaches that different clinicians have taken over time, what they've learned, and by listening to those webinars. So I highly recommend those if you're interested in that topic and engaging more on that topic. Additionally, we do know that many of the large centers in the greater metropolitan area have individual hospital-based protocols surrounding the approach to MIS-C. Also, there was a publication out of the University of Buffalo, SUNY School of Medicine, and the O'Shea Children's Hospital, where they published their approach. I can share that link in a future webinar. And finally, there are some groups working on convening and coming up with a consolidated approach, and hopefully we'll hear more from them in the future.
Thank you, Liz. Also, I saw that the New York City Health Department put out like an outpatient guide on how to recognize MIS-C in the outpatient world. And I think that is like also available for download on their website. And I think, this is well done. And again, our purpose here is all to share like resources. And I think we can also share a link at one point with you. A second question about that, will there be enough PICU beds and other necessary equipment and treatment for any future increase in MIS-C cases? Are the quantities of these children being actively monitored? Can you say a couple words about that?
Yeah, sure. So it's a good question, as we know that right now the cases have decreased sort of in keeping with the 4-week lag behind the acute COVID infections. And so we are seeing significant decreases in that epidemic curve at this time. But of course, we do want to prepare moving forward. So it's an excellent question. And we do monitor PICU beds along with other ICU beds. That is something that we do actively monitor from the State Health Department of Health and the New York City Department of Health and Mental Hygiene. We also work with our hospital associations and hospitals to monitor supplies of IVIG. And if there's a concern, work to address that. We have not had any concerns of either shortages at this point, and we will monitor those over time. As we are going to be seeing patients back in the office in mid-June, writes one healthcare provider, we will be taking temperatures and asking the appropriate questions. We have also had protective shields at our front desk and will have patients wait in their car until we are ready. Are there any other precautions we should be taking?
At least in my practice, we have, taking the temperature of every patient as this physician is writing. I think, the protective shield certainly is important. I would maybe add the signage that you, Liz, always are pointing out that we have on our website to download, just to alert patients when they're coming out. And I think the biggest piece is this pre-screening process of reaching out to the patients before they come to the practice and ask them a couple of guided questions. And I think that is also in one of our guidance documents, what should be asked appropriately, and then make a determination if these patients are like a risk to other patients in the office and or my providers and healthcare personnel or not. And I think with that, you're really covering all the most important issues to make sure that there's not a actively COVID positive patient walks into your office, and if so, that you can use these screening mechanisms to make sure that there is for example like a face mask on the patient, and he's been isolated in a single room before that and so forth. So I think all these are issues that we have not collected in one guidance, but we might we're still thinking about putting all this together about the patients. We have a couple of guidances out there that is again on our healthcare compilation, but again I think the physician here who mentioned that is doing the right thing.
Great, thank you. Another question that has come in, and a healthcare provider states many states like Arizona, Florida, California are showing increased cases after reopening. I was asked last week if coming from Florida to New York State, does that person need to be on 14 days of home quarantine? Are we asking people to quarantine after coming from any other states to New York State?
It's another great question. I've been asked that also multiple times. I think the governor, also the commissioner, made that clear very early on that we are not isolating people from other states, because we also don't want to be isolated from New York. Although I heard, although not official, that some states have been, thinking about that and actively promoting something like that. But I, at the same time, I think it's still pertinent to ask a patient, coming from a pandemic area, to think about showing signs and symptoms of the disease, and then if that is so, get tested right away, versus sending everybody who has been to an area into isolation, especially from Florida and so forth. There were a lot of questions also from international travel and international flight, and how should we handle those? Again, I think it's important to make sure that these patients are not symptomatic, and if so, that they get tested right away if they're falling into these categories. But at the same time, although I know as a fact from if you're traveling from Europe, from certain countries, that you will be asked to go into isolation at this time. I think it depends on the country where you're coming from. It's not just say oh yeah, I have been traveling internationally. Depends on how prevalent the COVID transmission is in that country and so forth. And that is going back to what Liz always mentions in the beginning with these maps that you are seeing. And I think as we are more and more picking up, also thinking about traveling, we should always keep a good eye on these official announcements from the CDC and or the State Department, and see if we're putting ourselves at risk if we're going outside the country. And the same also applies to patients or loved ones or friends who are coming back from international travel.
One other question that we've received that relates somewhat to some of the questions that have come up are we've had a number of healthcare providers reach out to us and say, how will we know early on to be prepared, whether in a hospital setting or another healthcare setting, for that next wave or that possible second wave of COVID? And in particular, there have been a lot of questions about this in relation to reopening that's going on now during the summer and any potential increase in cases we might see thereafter, protests, which could lead to increased cases, and then, of course, looking forward to the fall and the reopening of colleges and schools and the fall indoor activities. And so this has been a significant question we've received quite a bit. And that's part of why we have spent quite a bit of time on these webinars going through some of the resources online. Although they're available online, we do like to highlight these because we expect that many of you are not perusing our web pages in depth on a regular basis per se. But we want you to know that those are available so that when you do need to look for what's going on in your locality, those metrics are available to you. Some of those metrics of hospitalization and death, of course, occur a little bit later. And so we will also let you know that we, our colleagues in the New York City Department of Health and Mental Hygiene, our local health department partners, and in association with our hospital association partners, we regularly convene and we look at also influenza-like illness or COVID-like illness numbers as individuals come to the emergency department setting or urgent care settings. And we look at those numbers and we can see upticks. And we've recently published a paper with our School of Public Health colleagues showing that those numbers did uptick prior to the uptick in COVID confirmed cases. And those did track earlier and consistently. And so that's something that we can share in a future session, and something that we wanted to mention. Dr. Friedrich, anything else on that topic?
No, I think you pointed all the good points out. The one thing that I want to let you know, we are not letting down our guard here at the department. We are continuing, as Liz mentioned, all the monitoring of the healthcare setting very much in detail, and that we will know if there is a change in the current trajectory of cases and or hospitalizations and or ICU visits and or intubations and or ultimately deaths. And so we like at the department, we learned our lesson, and we will continue to keep a very, very, very close eye on those numbers areas, and if there's an uptick in certain regions, we need to have discussions about how to react to that. We also have now an army of contact tracers, and I hope, in the future that they will pick up, through the testing, certain hotspots earlier than we would see with hospitalization that usually comes, a week or two, maybe later, if there are symptoms, and therefore, that is, I think, like another early warning system if there's an uptick in certain areas. So with that, again, Liz, thank you, and thank you all for listening. And as Liz mentioned, the next presentation will be on July 2nd. And with that, I want to wish you all, a hopefully peaceful weekend, and take good care of yourself. And thank you for listening.
Agree, Dr. Friedrich, and we'll add on a happy Juneteenth celebration day tomorrow to everyone, and long overdue. This will be a celebration officially in New York State, which is fantastic. So celebrate Juneteenth Day tomorrow, and have a nice weekend. Thank you.